And our first talk for today will be on the preliminary evaluation for refractive surgery by Dr. Freddy Simon. Dr. Freddy is Director and Chief Refractive Surgeon at Tony Fernandez Eye Hospital at Alva. We all know him very well. So over to Dr. Tony.
Thank you. At the onset, thank you for inviting me for this topic. You put the slides on. Okay. So my first job in LASIK is obviously to work it up to see if the patient is suitable. And it starts from history itself. The patient should not be too young, depends on what age. I keep the age as 21. It's too old presbyopic age, they should know the problems with that. And you should understand what their expectations are from the LASIK. Recently I had a patient with best corrected vision of 6.9 and she wanted 6.6 vision for her job. And so unless you ask them what they want it for, you might end up in problems. And profession, if you have a player playing contact sports, it might be better to avoid LASIK and to do something surface. In the history, obviously we should ask about the contact lens wear. We all know that the contact lens, soft lens, should be avoided for 1 week before the workup and RGP for at least 3 weeks. Herpetic eye disease is no longer a contraindication for LASIK, but it's good to know about it and start prophylactic treatment pre and post LASIK. Then we should know if the patient has refractive error is constant. If it's allergic, then we suspect keratoconus. And certain contraindications for LASIK includes autoimmune diseases, keloids, again a relative contraindication, and diabetes. Certain drugs we'll have to know, sumatriptan, isotretinoin, which is used commonly for severe acne now. If it's being used, we have to stop it 6 months pre and post LASIK. And amiodarone. And surgery, we want to know about squint, RD surgery, prophylactic laser done. And personal history, pregnancy and lactation is important. We don't want to do the LASIK during pregnancy or at least 6 months. We had to wait for pregnancy to be over. After pregnancy and we should, after lactation, we should be doing it. Family history, keratoconus is important. If they have a family history of keratoconus, in a suspicious map is better to avoid. So the basic workup is usually done by the optometrist, and it's very important you have a good optometrist to assess the patient. You need to get the unaided vision with old glasses, refraction, cycloplegic refraction, intraocular pressure. And what they should be looking for is things like high astigmatism, best corrected vision less than 6.6, a scissor reflex, or frequent change in the power of glasses when you know it can be keratoconus. When you do the examination, start off with looking for deep set eyes and small papillary aperture. You can end up with a problem with putting your ring in for either LASIK or femtosecond. Slit lamp examination, obviously features of dry eyes, corneal irregularities, guttata, and even cataract you should be looked for. Retinal evaluation is compulsory and any predisposing retinal lesion should be treated. Ocular motility, if there's any obvious squint becomes obvious after the surgery, you should look for. The investigations we do in our hospital is tomography, dry eye evaluation, corneal diameter, epithelial mapping, pupil diameter, and aberrometry. Well, this is how you read a corneal topography. First you look at, obviously, if it's the patient's this thing. Then you look at the quality specification and you see it's okay written there. Then you know the quality of the map. Then you look for the keratometry. You see if the keratometry is too high or too low. And Kmax, if there's a huge difference between the central keratometry and Kmax, you know that something is wrong. So with keratometry, we don't want any keratometry above 47. And when we correct, we should not go below 35 if it's a myope, or above 49 if it's a hypermetrope. And Kmax should not be higher than the central, because central K is usually the highest K of cornea. If the Kmax is more than the central K, you should suspect keratoconus. And we should know that steep corneas are at a risk for buttonholes and flat corneas are at risk for free flaps. I look into the corneal diameter. It's anyway available in the Pentacam map. One, to decide on the diameter of the flap. We don't want too big flaps for too small diameter corneas. And again, BCLs, when we place BCLs after PRK, I find that small diameter corneas tend to have a lot of tight lens and severe pain post-op. And this is the horizontal white-to-white measurement which comes in Pendacam. Then we look at the axial scan. Things we are looking for is superior steepening. If it's more than 2.5 diopters is significant. Inferior steepening more than 1.4 diopters is significant. If the skew deviation more than 20 degrees, and abnormal shapes. You look at the first diagram on the left is inferior steepening, then superior steepening, then skew deviation more than 20 degrees, and abnormal shape, D-shaped elevation of the cornea. Then we go to the pachymetric map. There we look for thinnest pachymetry. If it is, you're planning LASIK, you need at least 500 microns, the thinnest pachymetry. If you're planning surface with no other abnormalities, at least 480 microns. And you look for the displacement of the thinnest point, especially in the y-axis. X-axis is relatively stable, but no, y-axis is relatively stable, and if it's more than 500 microns difference in the y-axis, then it's significant. Then you look at the pachymetric difference between the two eyes. It should not be more than 30 microns. And the superior-inferior difference also at the 5 millimeter zone should not be more than 30 microns. So there you see a thin cornea difference, and then you can see the thinnest location in the y-axis is more than 1000 microns. And pachymetry is also, we use it to calculate the residual bed. For LASIK, some people say 275, I keep it as 300, and for PRK 400 at least. Then we look at the elevation maps. What we look for elevation maps is we look either as an isolated island which is seen in the central 5 millimeter zone, or a tongue-shaped elevation. Well, the anterior elevation, if you see, it should be, if it's more than 12 is significant, and posterior elevation more than 15 microns is significant. So if you look at the map, the top map is anterior elevation is more than 12. The posterior elevation, you can see the tongue-shaped extension into the center, and an island in the center and posterior elevation. Then we look at the Bell-Ambrosio scale. There are lots of values in this. What I tend to look for is one of the D values and the total D value, the progression index, and the artmax. Artmax ideally should be above 400. Then routinely we do dry eye examination, Sherma and T-Butt. If you have a dry eye diagnostic system, you could use that too. Pupil diameter, you look for large pupils, especially in mesopic light, where it can cause more of glare. Again, that is controversial whether it is a pupil that causes the glare. And you can adjust the optical zone accordingly. I do epithelial mapping. They say early keratoconus, the epithelium tend to compensate for the ectasia, so that you might get thin epithelium in the area of ectasia. And you might pick up keratoconus even before topography. But I must admit that I haven't cancelled any case because of a finding from the epithelial map. This is a typical donut picture you see in keratoconus, where the thinning of the epithelium in the center because it's ectatic, and peripheral thickening of the epithelium. Aberrometer usually we do for customized correction or when looking for higher order aberrations. Still we tend to miss a few cases because at the current screening methods we tend to miss a few cases which fall within the normal. So there are newer diagnostic techniques which have come, like epithelial thickness, Bowman's thickness, Brillouin spectroscopy, elastography, and biomarkers also. I haven't done any of those. We don't have any of these in the hospital. But one thing that should come is artificial intelligence. There's so many variables in LASIK workup. So if we can put everything into, all the data into one machine, and it can give us the risk factor for the LASIK, it will be useful to us. So to conclude, LASIK workup includes: 1, assessing the patient's needs and expectations. That's as important as your workup. Assessing any significant history, assessing the refractive error accurately, and assessing the patient's suitability for LASIK. Thank you.
Excellent talk, Dr. Freddy. Just one question. Yes. You showed all the dry eye workup equipment.
Yeah.
So once you know that, suppose the patient has got the dry eye, that is a severe dry eye. So how will you treat? Then how much gap you will give to do the refractive surgery?
One, the dry eyes, unless they are wearing contact lens for a long time and all, we get very few patients with dry eyes. But generally 4 to 6 weeks at least I'll give some artificial tears and recheck them. And if they're still having dry eyes, I would advise against treatment or go for some maybe a smile or something which
So
is
what
less.
I do normally, I have got the equipment which can even treat the dry eye, especially eye light or the other
Yeah, that's
different
only for-
modalities.
Yeah.
So after doing that, after 3 weeks, probably we can take them for.
Yeah, that's again for meibomian glands mainly
Yeah.
for that, you know.
Yeah.
But all dry
Meibomian.
eyes we cannot treat with the
Yeah.
equipment. Yeah.
Thank you, Jairam. Anything to say? Excellent talk.
Okay then.